Thomas Ebert. I'm unfortunately not a nephrologist. I'm very sorry. I'm just a poor diabetologist and endocrinologist, but being responsible for this Q&A session now, which I'm looking forward to. And we have received quite a lot of questions from you all, and maybe we can sort this into 3 different topics, more generalized questions, and then specifically questions related to SGLT2 aspects, but also the incretin-based aspects. And maybe we start with one question from the audience, going directly to Peter. So you mentioned that it may be difficult to measure the eGFR changes by serum creatinine, also goes into your presentation, with weight loss. So what is the direction of the bias? So can you repeat this once again?
Yeah, I think Hiddo also alluded to that very nicely, that the challenge is you may see a benefit on kidney function, which is actually not true, but is due to an improvement in the filtration marker, creatinine, or as even though I suggested that maybe cystatin C worked because that worked in our hands, then in other settings, cystatin C may not be optimal. And then you may need this new system Hiddo was talking about. But whether that's necessary, I think we wait to Hiddo, but I'm curious what you think. But the bias would be that you see an improvement if you lose weight, which is not there.
Creatinine is produced by muscle mass, remember? And thus if you reduce your muscle mass, you reduce the production of creatinine, so your serum creatinine concentration will decrease, and you think that you have a good kidney function, not because you reduce the filtration, but you have changed the muscle mass, and that's the bias.
Brilliant, thank you so much. So then maybe, yeah, can of course.
Yeah, because I'm aware of that. If you go under GLP-1 receptor agonist,
yeah,
you can reduce your weight, your muscle mass, or whatever. But then you start doing more exercise, as you said, and then your muscle mass can be increased.
Yeah.
And if it is increased, then you will see an eGFR reduced, which is not actually true. Yeah. Your eGFR is better because you have more muscle mass.
Yeah.
So I would like you to have a comment about like what is going to, maybe it's going to happen in 5 years' time about like the patient's going to get better, but the eGFR is going to be worse.
But even if that would happen, then it would still be a bias because of changes in exercise, changes in drug use, you don't know. So that means that you have to measure GFR.
Brilliant. Well, thank you so much. So then maybe let's go directly to the SGLT2 related question, and maybe we start with you, Beatrice. So there's one question that on the class effect in SGLT2 inhibitors. So are there any reasons to choose one SGLT2 inhibitor over the others in specific cases? So what is your thoughts on these?
This is the question of the questions. I believe this is a class effect. At least in dapagliflozin or empagliflozin, the results are mostly the same, or they are not the same, but they are quite related to each other. That I believe that they are. If you're still using dapagliflozin, let's go for dapagliflozin. If you are using empagliflozin, let's go for empagliflozin. But the reality is that you have to use SGLT2 inhibitors. I was thrilled about to hear like 50% of the population of the CKD population is going to be under SGLT2 inhibitors in the near future. As we are supposed to follow the guidelines, and the guidelines doesn't say anything about the differences between one SGLT2 inhibitors or the other ones. So I will go for SGLT2 inhibitors in general.
So to make it very simple, if you look at the molecules, dapagliflozin and empagliflozin, the part of the molecule that binds to the SGLT2 transporter is identical. Some people even say that Boehringer Ingelheim was lucky because the original producer of dapagliflozin made a mistake in their patent, so that Boehringer Ingelheim could patent empagliflozin. So this already tells you how similar the molecules are. And then everything that Beatrice said is right. The effects on surrogate, the effects on clinical outcomes are the same. Why are the doses different? Just because they were developed in different periods. Dapagliflozin a little earlier, the company was careful, as BMS, careful not to choose too high doses because it was the first drug in class. But in the end, many people are using EMPA-10 and DAPA-10.
Brilliant. Thank you so much. Another question on SGLT2 inhibitors, maybe for you, Natalie. So is there any data that suggests a benefit of an early initiation of these SGLT2 inhibitors in patients with diabetes, but with normal eGFR and without any cardiovascular disease?
I'm not sure that we've studied those people without cardio, because as I said in my talk, the primary populations that we've looked at are people with diabetes and high risk of cardiovascular disease or in heart failure. So obviously anyone else can jump in if I've missed a trial, but I don't think we've really studied people with normal levels of eGFR and no prior cardiovascular disease.
I think, Natalie, you're completely right. There are no dedicated outcome trials, but let me speculate. If we look in diabetes, we can see that the benefits of, and the question is, which benefits? Is it heart failure? Is it kidney failure? Is it reducing anemia? Is it reducing cardiovascular outcomes, mortality, all-cause hospitalization, reduction in gout, reduction in anemia? So there's so many benefits. And then if you look at these benefits in diabetes, no diabetes, high GFR, low GFR, with heart failure, without heart failure, with cardiovascular disease, without cardiovascular disease. It's all consistent. So if you ask me, are these drugs beneficial in people without diabetes, preserved kidney function? It must be. But it depends on the outcome. It depends on the risk factors, which outcomes you want to look at.
So in people with diabetes, without declared study, and it was like in people without cardiovascular disease, but you need a lot more time to see any benefits in people without anything. So if you start taking SGLT2 inhibitors without diabetes, or with diabetes but without any cardiovascular disease, then you will see the benefits, but it will take a long time to see the benefits. For example, if you've got like gestational diabetes, then you are more prone to have diabetes in the future, then you are more prone to have cardiovascular disease, and you eventually you will have more problems. So what not starting taking those medications before, we don't know, and maybe we will ever know anything about that if you start taking medications, because when you start taking SGLT2 inhibitors, you still have one disease or the other or both.
Perfect. Thank you very much. Very important points. So maybe one last question for time reasons on SGLT2 inhibitors. We got a question on a specific subgroup of patients with chronic kidney disease, which is patients with polycystic kidney disease, ADPKD. Are you aware of any studies on SGLT2 inhibitors in this field? And please comment on these data. Maybe you have any idea? Or
yeah, I have. But if the others... Nothing to add. Well, there are 3 animal studies. One was positive, one was neutral, and the third one was negative.
Very good.
So this is very nice. Shows you how important animal studies are. They are useless, in my view. I'm just kidding. And so we didn't study them in EMPA kidney. We didn't study them in DAPA-CKD. A taxi company approached us a couple of years ago, and they said, we have been transporting patients to your hospital for many years. We've made a lot of profit. Here's the profit. Do with it whatever you want. So we got a lot of money, and we could do with it whatever we want. What did we do? We designed a clinical trial, renal life cycle, to assess the benefits of SGLT2 inhibitors in people with a very low kidney function, below 25, or on dialysis or kidney transplant patients. 2,000 patients in total. More than 800 patients are already randomized. In this trial, patients with polycystic kidney disease are allowed to participate, and we'll have more data in the future. And there is one dedicated outcome trial in design in Germany. Hopefully will start late this year, early next year.
Maybe it's like if it's too late, they are not under any medication, and if it's too soon, they will go under tolbaptan. So if they are taking tolbaptan, they are not allowed to take maybe SGLT2 inhibitors or the other way around.
Why not?
Well, because I think it's my point. It's like the way the patients behave. when you are under tolvaptan, you already pee a lot. And then you are under tolvaptan and under SGLT2 inhibitors at the same time. I don't know about the diuretic effect of both together. It's like a matter of thinking about the patients, not about many of my patients left tolvaptan because of these problems. They were all the time going to the bathroom, and it was a problem for them.
So I thought that you wanted to raise something else. SGLT2 inhibitors don't change urinary volume. That has been demonstrated very clearly in the Dapasol studies that were published. So I don't think it's a problem from that perspective, but it could be another problem. SGLT2 inhibitors increase copeptin. And copeptin is a risk marker for disease progression, and that's why we use tolvaptan, right? So if you are on tolvaptan and there may be interactions, so it is a valid point to think about tolvaptan use in combination with SGLT2 inhibitors. In our trial, patients who are using tolvaptan are not going to be allowed to participate.
Perfect. So then let's switch to the incretin-based therapies. And we have the first question on semaglutide data. So in some diabetic individuals, we observe very little weight loss effects with up to 40 milligram of oral semaglutide. So a question not coming from Germany, as we don't have it. Any reasons for this? So the question related to GLP-1 resistant individuals. Could you already comment on this? I also have some diabetologists' opinion on this, but
yeah, I think it's interesting that we see a very wide variability in the weight loss. And everybody have heard about the person who lost 30 kilos and want to be like that person when they are weighing too much, and that's what they are asking for. And then on average, the weight loss may be a much less. And therefore, as was also mentioned before, there are different factors, and maybe whether it's driven, whether your, let's say, eating habits are driven by hunger or by habits or anxiousness, or whether it's a biological effect, I think we don't fully understand yet. There are different ideas about how this could be. And at least we have seen this variability. It has been suggested, could it be related to, for instance, your C-peptide levels, your insulin production and so on, your degree of obesity and so on. And that has not been possible to really explain this. So it may be more psychological features or mental things than something we can measure in the lab.
Mm-hmm. Mm-hmm. Another question towards the weight loss of these drugs. Are there any possibilities to predict which individuals receiving these drugs might become sarcopenic, especially in the context of in advanced chronic kidney disease? Are you aware of any information on this? Would you recommend doing a DEXA scan or a bioelectrical impedance measurement prior to initiating these kind of drugs?
No, and I think I would like to add that remember that studies like the FLOW is done not with the obesity dose of GLP-1, but with the dose that we use for diabetes, for glucose management. And therefore, you can say the weight loss will on average be quite modest. Like in the liraglutide trials with LEADER and so on. So and you are not required to be obese to go into the trials. You could be lean, but we'll learn more by looking from the data. But I don't think we can have a predictor right now, and I would not recommend DEXA scans.
So maybe one last question, very practical question. So what is the maximal dose of an GLP-1 receptor agonist for treatment in patients with end-stage kidney disease? Maybe this goes to you or to you all.
They are not being tested yet in end-stage kidney disease.
Yeah.
There are very limited data on that. So you could say. It seems that at least for some of them you can use them in kidney failure, but there are very small data, and generally the recommendations is that there are no data on this. And the problem has been reported to be that there's more side effects like nausea in those with very impaired kidney function. We'll learn more about that from the FLOW trial, where people will have more impaired kidney function than in many of the other trials. In the LEADER trial, which was one of the first outcome trials with GLP-1, they had kidney function down to 20 when they started or so, but and that worked okay, but really kidney failure, there's very little data.
Yeah. For tirzepatide, which is already on market in some countries, it's possible to use even in patients with end-stage kidney disease without any those escalation issues. So I think for time reasons, thank you very much for this inspiring discussion section. Thank you all.